Right, so thank you for the invitation and thank you for coming here. These are my disclosures. So when you think about what do we need in future, it depends on what the challenges are today. And our first speaker in this session, Dr. Saw, highlighted some of these challenges and which surround around device procedure, which surround around the device, maybe the procedure, some of the data deficits that we have, and how do we increase the awareness. So major complications of this LAA closure, specifically Watchman, have reduced as we learn this process through several studies, but it's still to a point where when you're offering this therapy as a prophylactic therapy, then really we want it to go further down. And pericardial tamponade, even though it's less common, it's still around 1%. A variety of factors that go into why somebody has a pericardial tamponade. You see either early tamponade or late. Early is usually related to the transeptal puncture or manipulation of device in the LAA, or you see delayed tamponade, which sometimes is due to microperforations, commonly in the setting of initiation of a NOAC or low molecular weight heparin, pulmonary artery bleeding, and sometimes patient factors get into the play. Some of the challenging LAA anatomy, shallow depth, when you're trying to get a bigger device with a limited depth. And then certainly the device features, open cell versus closed end or length and number of anchors, all of these play. The current Watchman device, as you all know, is more of a spherical or a square. If you want to use a 27 device, you need ample depth. So not all appendages have adequate depth, so you're trying to always push the device in, cheat the feet maybe, trying to accommodate that reasonable compression that you want for that device. So, and that's one of the challenges with this particular generation. Hopefully we'll get little less of an issue with the next generation Watchman Flex, which not only has a closed cell, but you also don't need as much depth. And the deployment will be a little bit different as compared to the current generation. Obviously, safe procedural technique, safe transeptal will still remain the key no matter how good the device is. And then imaging right now, the standard of care is transesophageal. Except a few handful of centers, most of us are doing this as a general anesthesia with TEE. But TEE has some implications. It needs GA, it needs an anesthesiologist, needs an echo doctor, comfort of the patient, and safety in elderly patients with COPD. It also adds to a scheduling issue for your program coordinators. You know, you have to get the anesthesia, echo. So it would be really nice in future if you can get away from the general anesthesia and TEE and still be able to deliver safe and effective procedure. Intracardiac echo may or at least has some potentials. It doesn't need general anesthesia. It's comfortable to the patient, or less discomfort, less personnel involved, but obviously there are challenges. The technology is not exactly where we all want. There are limited views, that there are tissue dropouts issues, the X-plane issues, live 3D, suboptimal images if you leave the transducer in the right atrium. You could navigate that transducer in the left atrium, but that also adds a layer of complexity. Does require an additional venous access, which can cause complications and obviously has a learning curve. But it does have some potential, and there are scant reports of its feasibility. This is from Dr. Reddy's group, where 27 Watchmans were implanted, and with really no major complications in this subset. There is some sizing discrepancy between ICE and TEE that should be put into context, but not enough to change the device size. This is another study which was using Amulet. It's a retrospective single study, about 100 devices on TEE arm versus ICE arm, and you can see there was no difference in major complications. Yes, these are selective, experienced single centers, but if the technology is good and we focus on teaching and learning, maybe it has potential. And maybe with these ICE cases, we combine this CT scan pre-procedure planning, get more of sizing. CT has various advantages in itself. We are seeing increase in the CT pre-procedure planning for commercial Watchman. The patient doesn't need to be NPO, so less likely their LAA pressure will be lower. It's complementary to echo, and maybe it gives you a little better evaluation of these complex appendages. So data, there's very good data. This is the 5-year analysis from our PROTECT-AF and PREVAIL trials that shows definitely significantly lower hemorrhagic stroke with the Watchman compared to warfarin, and consistently reduced cardiovascular mortality, all-cause death, and very significant reduction in major bleeding. But if you look at this pharmacotherapy in this commercial indication, post-implant, warfarin is given for 45 days, and then a patient gets a TEE, and then you decide if there is no thrombus, no major leak around the device, then you discontinue the warfarin and continue high-dose aspirin and clopidogrel up to 6 months. The issue is that it does require 45 days of warfarin, and so what about patients who aren't candidates for oral anticoagulation, even for short duration? I think that's a data void right now, and which is, if you look at the Pinnacle registry, half of the patients are not on anticoagulation. So there is a big subset of these AFib patients who are not on anticoagulation. How can we offer them this commercial Watchman? ASAP-2 is a clinical trial which is trying to investigate this further. Patients who are not a candidate for oral anticoagulation are 2-to-1 randomized to either Watchman or medical therapy. If they're into Watchman, they get aspirin and clopidogrel up to 3 months. And this is important because this graph just shows you that really the bleeding difference between Watchman and warfarin starts separating after 6 months once the oral anticoagulation and clopidogrel is discontinued. So if we can in future, depending what the ASAP-2 trial shows, if we can offer this Watchman without having a need to give oral anticoagulation and maybe a shorter DAPT, we may have more benefit with this therapy. Device-related thrombus, if it depends what registry you look at, but somewhere around 3.7 to 4%. It's not very common, but when it happens, it does increase heart rate for everybody. You do have to anticoagulate these patients, and yes, this doesn't cause stroke in all patients, but definitely has a causative effect that these can cause strokes. So you want to anticoagulate these patients, but these are already the patients who are not long-term candidates, so it makes the life a little bit difficult. And timing of DRT, it doesn't always happen within those first few weeks, so that's also a little bit of challenge, like how long do you continue this? You can see these yellow dots, they're spread for several months. This is detection of DRT. And what that tells you is that even if you give 6 months of anticoagulation or DAPT, DRT might still stay. So we need something else to prevent this DRT. And this is just totally my hypothesis, like, is it the same bare metal drug-eluting type phenomena, and can we just do a drug-eluting Watchman to resist that early thrombotic concept until it fully endothelializes? And I do not know how far the sponsors are or whether this is a reasonable or not reasonable idea, but certainly something to think about. The release pin is slightly more thrombogenic than the fabric. Maybe you reduce the surface area, and the next generation Watchman Flex does have this addressed partially. And then if you really want to look at the next generation Watchman, maybe include the biosensors, measure the LAA pressure that could help you with the heart failure therapies or give AFib burden, just in concepts. NOACs in non-valvular atrial fibrillation, really very strong data, multiple trials, really is the standard of care over warfarin, and very effective in decreasing the stroke and effective in bleeding as well. How do we compare NOAC versus Watchman? It will be a tough trial to do, but ultimately I think we may need to do this to convince our general cardiologists that Watchman could be offered as an alternate to NOACs. PROG-17 is an active trial going on on this topic, but 400 patients may not be an enough sample size to address every single answer we want. And then the question is, what about these combination things? Watchtower is currently recruiting patients, but can you combine these with other therapies, MitraClips? Can you combine with atrial fibrillation ablation procedures at the same time to make it more convenient to the patient. Obviously, reimbursement will be an issue in future if you're obviously doing 2 procedures at one time. Awareness and shared decision-making. Awareness needs to be a little more, not just for the physician providers, medical professionals, but even patients. They may not be aware of this therapy is available. It's not uncommon to see patients in clinic who are having second, third, fourth, fifth bleeding episode, but have not heard Watchman is available. When CMS approved, really they emphasized on shared decision-making involving patients, cardiologists and non-implanting physicians, and also involving the patients in this procedural implant. So really we need a multi-pronged attack, some improvement in devices, learning the procedure, making it a little less invasive for the patient, data and guidelines, thrombus-resistant devices, atraumatic tip, and really if we can get away with no oral anticoagulation post-implant and just get patients involved with shared decision making. I do think that patients need to be aware of this at the time of AFib diagnosis. You may not offer them, still tell them that there is, you have this new diagnosis, there are NOACs that we're giving you, but if you do run into problem down the line, there is something else that could be considered. Unless we offer it that way, I don't think it's a completely shared decision making or informed consent. Right, thank you.